ability to get in. So we are admitting everybody now. Good afternoon, everyone. As people are joining into the meeting, just as a couple of reminders, my name is Dominic Zerlo, and I'm with the Department of Health, and I'm here to help with regard to making sure the committee meeting itself continues to move forward well. Just as a reminder, because we do record these meetings and the recording has started, we do ask that people watch and use appropriate language during the meeting, simply because we do want to be able to post it up on our website. And occasionally, if people are using language that's not appropriate for all ages, it can delay in us being able to post it, as we have to edit it at that point. And we would rather not edit and just have things as they are presented. And then that's also part of the reason why we do not have cameras on for everyone. And there's two reasons for that. One, again, to make sure that everything is appropriate in the video. And the second one is because we have so many people who participate from other portions of the state that do not necessarily always have the greatest internet access. The video, unfortunately, takes up a lot of bandwidth and causes people to drop off of the meeting and have to rejoin. And that does happen sometimes now anyway. We just try to minimize it. And so so we try to keep only a few people with videos on. And so with that, I will turn this on over. This is the End of Life Care Committee, and the chair of it is Dr. Larry Leeman. And so Dr. Leeman, I will turn it on over to you.
Great, thank you, Dom. Great to see we have a nice big crowd today. I thank everybody for coming here and participating. Before we start, I want to just go over a little bit of a potential model for our next few meetings and our next process. So this meeting, in a minute, I'll introduce Jenn Clemente, who's a thought leader in end of life and a psychedelic chaplain who's going to talk about some of the role of spirituality in end of life care. For our next meeting, which is tentatively planned for the 20th, Danielle, our death doula, who's actually on the call, is going to talk about the role of psychedelic death doulas. And then for April 3rd, James Brown will be talking about issues of pharmacology that apply to end of life care. So we sort of have 3 meetings where we're covering each of those areas. I want to just put a call out, if I'm sure there's things maybe we're not thinking about. If there's someone else that should come talk to us, please share that with me, either in the chat now or personally. I have thought about if we could invite somebody from Dene or Pueblo, person who may want to talk about relevance to working culturally with end of life care. After those 3 meetings, my hope is that we've had a lot of interest in having a blended meeting where people can be in person and have a conversation. Actually, there at the same time, though, it would be blended, so people online would be able to watch and contribute. So I think we'll work on that for potentially end of April sort of timing there. More or less looking for averaging about every 3 weeks on meetings. So you'll see we have a 4-week break here, and then we have them every other week for a while. So the format today is going to be Jenn Clemente, who is our thought leader in psychedelic end-of-life care, is going to share her presentation, which I think is about a 25-minute presentation, 30 minutes, and then we're just going to have an open discussion. Well, first we'll have questions that are directed to Jenn, and then an open discussion on different issues that have come up. So Jenn, thank you so much. We really totally appreciate your volunteering to be here. And I've had a little peek at your presentation, and it's quite interesting and exciting. So thank you.
Thank you. Should I go ahead and share?
Yeah, go for it.
Okay. Let's see if I could do this. Share this window. Okay, do you see it?
Yes, we do, Jenn.
Okay, great. So I'm calling this a framework for end-of-life care within the Medical Psilocybin program. And for me, when I'm thinking about New Mexico, I think of Shiprock when I think of spiritual care and spirituality and sacred places. So I tried to represent Shiprock in this presentation. So those of you who've been to Shiprock, tell me if I got it right. Or tell me if AI got it right. And do you see just my presentation right now, or do you see my notes as well?
Right now, just seeing the framework for end of life image.
Okay, great. Okay, wonderful. Well, so I just wanted to start out by saying, I've had the honor to spend a lot of time on this topic over the past few weeks and probably over the past few years as well, but most concentrated in the last few weeks. And I've had a chance to hear from a lot of people on this realm, this nexus of spiritual care, chaplaincy, and psychedelics. Some of whom I believe have joined us today. I can't see who's here, but I trust that some of the folks I've been speaking with have joined. So thank you if you have. And so I want to just kind of start by saying that, despite my attempt to gather all these inputs and present a fair portrayal of where this area is currently and where we might go, I wanted to disclose that my process of creating this presentation was really based on many of my own questions. And I kind of imagine many of you are asking the same ones, such as like, where do I fit in with my skill set and expertise, or my desire to have skill set and expertise? Ultimately, how may I serve this population, and am I prepared? And then most importantly, what additional training and experience do I need? And I know that's a question that's being answered by possibly another committee, but I think it's fair for us to start asking these questions. So as the committee really refines this act and has these conversations, I would encourage clarity, getting clear around the interdisciplinary roles, the scope, the aligning of the scope and the pathways that we need to build that ensure that existential suffering isn't overlooked because it doesn't fit in this, little diagnostic box. So our goals should be, 3: dignity, safety, or 4 of them: access, dignity, safety, and integrated care that aren't like restricted by having integrated or regulatory silos. So where do I want to start here? I think a good place to start is looking at Dame Cicely Saunders' definition of total pain. And, this did really reframe pain management from, just merely symptom control to meaning-centered care. I think she created this definition in the 60s. She's the founder of the modern hospice movement, for those of you who don't know, which I'm sure everybody here does. So this idea of total pain really, I think, legitimized the roles of chaplains as well as, social workers and anybody in that interdisciplinary team that works alongside the medical team, the medical roles. And this is kind of informing, spiritual care, the contemporary approach to, existential assessment, ethical accompaniment. And today, I really believe it's supporting this emerging discussion around psychedelic-assisted palliative care. So, under the Medical Psilocybin Act, end-of-life distress is explicitly included as a qualifying condition, and that's why we've been meeting. And this really positions the state as a national leader in acknowledging existential suffering as a legitimate medical concern. So it also creates that imperative to facilitate medically supervised experiences that are capable of surfacing these profound questions of, meaning and identity. So what is spiritual care in psychedelic medicine? So in the psychedelic context, people aren't really only grappling with meaning or belief, but also being itself, the nature of consciousness, non-duality, mortality. And this really comes into focus during end-of-life settings. So the focus is really around the spiritual, existential, religious, and theological concerns, or CERT. And that term emerged as a shared language for naming spiritual and existential clinic care in the clinical and quasi-clinical environments. That's what I found out. And then it's all about maintaining the sacred witness role, non-directive presence, and then supporting experiences that can't be immediately interpreted or resolved. So that's kind of a basic, kind of framework for spiritual care in psychedelic medicine. So the term psychedelic chaplaincy, I came across this, I think during the pandemic, there was a webinar that Harvard Divinity School put together, and I think Charles Stang came up with this term or brought it together, and I was really, it really piqued my interest, and it's just been kind of building in my mind ever since. So what it really means is it's a form of professional spiritual care that supports individuals engaging with psychedelic experiences by addressing spiritual, existential, religious, theological, and ontological concerns that may arise before and after these experiences. So the components of this are really like, the meaning making, spiritual assessment, preparation and integration support, non-denominational client-centric care, and ethical safeguarding against that meaning imposition. So then we can ask, why do we need formal training? I mean, a lot of us have, done parts and pieces of this work. There's, chaplains on one side, and there's, death doulas and other practitioners on the other. And so, we're kind of trying to figure out why we need more formal training and if it's necessary and how do we get it. And so I just wanted to outline some of the reasons why. And I think these things are pretty obvious. Obviously, during a psychedelic experience, there's heightened suggestibility. It's easy for people to unintentionally impose meaning, even if you're wearing a shirt with like Shiva on it. Are you imposing meaning during a psychedelic setting? The complexity of being non-denominational is real. There's a lot of different assumptions that maybe bump up against somebody's tradition. So, for example, a Baptist Christian may not have the same values as a more contemporary kind of New Age Christian, for example. Thirdly, this is high stakes work. There's a trauma that can come of it. Somebody could die during an experience or have more anxiety around it. There could be a lot of ontological shock. Now, those of us who've been using psychedelics or experience with it have all probably experienced this before, where something was just, blew our reality away. And these things can be very much amplified in end of life or terminal illness situations. There's also this ethical risk. We have a lot of power differentials that can come up. Patients are super vulnerable. There's questions around, use of touch. And also guru dynamics around, the role clarity. So we want to make sure patients are protected against those potential power issues that come up a lot in psychotherapy or in, in religious settings. So the idea here is that, without formal training, anybody who's a care provider may unintentionally exploit any of these vulnerabilities at the worst, or even just fail to recognize unmet needs and signs of distress. So if we have good training that could establish clear ethical obligations, reporting pathways, and standards of care, we could probably do some good in preventing harm and ensuring our patients are well protected. So this came out of a study based on Paletsky's work from Journal of Psychopharmacology in 2024. So he outlined the unaddressed spiritual and existential harms in a really nice, easy to understand way. So these are the 5: meaning disruption, identity disturbance, spiritual bypassing, interpretive imposition, and delayed effects. So again, avoiding engagement with meaning making and spiritual impact doesn't reduce the risk, but it could actually shift harm into unmonitored domains. So under this framework, the psychedelic chaplain functions as a kind of infrastructure for existential harm reduction and ethical accountability. So I would argue, and I fall on the side of this, that it really makes it necessary by design rather than optional. And I know that in the current language of SB 219, this kind of spiritual care is optional. So that's one of the questions and issues I'm raising in this presentation. So here I wanted to give you a sense of like the gold standard for a psychedelic chaplain role. And this is based on the traditional chaplain role, but with the psychedelic training added in. For those of you who aren't familiar, it's a pretty rigorous academic path. So it starts with getting a degree from an accredited university, an MDiv or an MA in chaplaincy or spiritual care. I know some of us have, degrees, maybe bachelor degrees or pieces of paper from other organizations that give us that sort of credibility in doing sort of ordained ministers of some organization or the other. The chaplain role really requires, a lot of places at hospice and hospitals require you have an MDiv. And then there's that layer of spiritual or psychedelic specific education, which most of us have done or are in the process of doing. And this really goes into, ethical boundaries, setting, and hopefully, building in that spiritual assessment and understanding what happens from a biological perspective. and understanding suggestibility. And then, of course, there's a supervised practicum. This would include that real world experience in a hospital, palliative care approved settings. And this comes from the CPE or the CPU that you have to do to get that experience. And then there's board certification that comes along with this role, traditionally speaking. And then there's this idea of mentorship, which is that ongoing education, professional development, working in teams, understanding, like learning from somebody who's been in the field for a long time. And I can tell you, these are all really hard to get. They take a long time, and they are, they cost some money. Okay, so then let's look at the training gaps. And there are many. So I guess the question I've been having is like, are we prepared to place these individuals into service today? Do we have enough people with the right amount of training? So there was some research I found that was done in September that provides a really nice analysis of about 13 psychedelic-assisted training programs in the US. And it's trying to clarify how organizations are preparing facilitators, what content they're including, where the gaps are, especially in areas like spiritual, existential, religious, and theological competencies and the CERT. So of course, it's highlighting a lot of areas that need improvement, such as, continuing education opportunities for graduates, really establishing parity across physical, mental, and spiritual health within psychedelic assisted care. And that, so like mental health clinicians would gain that basic competency in spiritual health, and spiritual health providers would gain competency in behavioral health. So that's what we mean by parity. We're also really needing that field-wide standards for training for these kind of providers. Also many active mentorship programs. I know that's something I was really feeling a need for when I was a chaplain for 6 months. I really was trying to find a mentor, and I didn't have one. And then clear guidance around what the competencies really are. So as I see it here, these gaps really point to a discipline that's still in formation. I mean, I guess I would say, we're building the plane as we fly it. And many of us who are looking to piece together our competencies without a clear roadmap really know this problem too well. So if the goal is to work toward a mature, regulated field, how do we do this? And that's what I'm hoping to surface here in this conversation after this presentation. I could see, building collaboration with and around this idea of spiritually responsive care that requires multiple rules that could fill it. And we also need to adapt to scientific developments, social developments, regulatory and economic developments for this field to mature. So what traditionally was like a chaplain role, probably needs to mature and kind of adapt a little bit to this need and these kind of emerging standards. So again, as I was talking to everyone about this, I think a lot of us centered on this agreement that any early implementation challenges in New Mexico would likely require a more flexible, hybrid, and phased approach to building out this role. So as you see, the Medical Psilocybin Act permits but doesn't mandate spiritual care. So there's an assumption that New Mexico may lack sufficiently trained chaplains statewide in early implementation in these early days. So would a phased competency-based approach work better? So we could anchor it possibly in clinician authorized care plans that specify spiritual health functions. So in this initial framework, the licensed clinician could retain that responsibility and designate the preparation, journey, and integration roles per patient needs. And those roles could be the chaplain, doula, or combination per availability and competency. And one way I was thinking through this more recently is to how could we automate some of the matchmaking and team assembly to ensure standards and adequate coverage. And priority coverage would include, medical safety, psychological support, spiritual distress, relational and legacy concerns with clear escalation pathways. So this is kind of a look at the different phases of how this could go. So phase 1, years 1 to 3, would be spiritual care competencies, prioritizing those competencies over the fixed roles to ensure that we have access while building capacity for specialized care over time. And you can see then we move to, eventually to a full interdisciplinary care model. So again, if we build that more phased, flexible approach, we could preserve the patient safety we need and the ethical care it deserves during a workforce build-out time where we can maintain clinical accountability. But again, as I mentioned here, we'll have to provide some clear upgrade path toward more robust interdisciplinary care that supports the flexibility we need while not abandoning spiritual health as a core dimension of care. And one thing I was thinking through is if we rely on clinical discretion alone in building out those care teams, we might under-identify spiritual or existential distress. And so we may not get, the full coverage of patient needs. So we need that explicit language, standardized processes paired with the right tools to ensure balanced care. So these are some suggested pathways to the practice. So, we just reviewed that, gold standard for psychedelic chaplain training. So this part of the presentation needs to consider how they compare to other roles. And I think when we hear from Daniela with the death doula role, we can start to kind of get a better picture of this. This is just an initial slice. So, there are many death doulas and wellness providers who may not hold, formal licenses, but they do play really distinct and valuable roles in end-of-life support, particularly in providing that presence, advocacy, guidance, and continuity of care. So to function safely within the psychedelic-assisted model, it would make sense for these practitioners, doulas, and wellness practitioners, shaman, community leaders, etc., to demonstrate defined competencies appropriate to their scope. And so again, we'll hear from that community in the next meeting, but this is just a start. So this model I have here considers cross-competency. Again, makes sense for mental health clinicians to have some literacy in spiritual and existential care, and then spiritual providers, including chaplains and doulas, should demonstrate basic competency in behavioral health, trauma awareness, and risk recognition. So, what we want to do most at the end of the day is ensure that the care providers, regardless of who they are, don't dismiss or misinterpret profound experiences, because that can undermine meaning making and negatively impact patient well-being. So I'll just take a moment so you can take a look at this. So I have here the roles here. The first one is kind of everybody in this unlicensed realm, and then the chaplain, and then the license holder. And the foundational experience would be, end of life and somatic support plus complementary therapies, which most of them have. The chaplain has the MDiv and board certification, and the license holder is that, making sure that there's safety and they have the license. And then we're looking at, this build out of relevant New Mexico line training, which has psychedelics and facilitation training, peer support, real world experience with in-depth recommendations, group supervision, mentorship, hospice, palliative education, and then maybe like with the NIDA or equivalent exam completion on top. This is just for everyone's consideration. This isn't me telling you what to do, but I thought I'd build this out a little bit. And then for the chaplain, they would need psychedelics and facilitation training, again, peer support and mentorship. And then the license holder, has the psychedelics and facilitation training, meaningful palliative care training of some sort, and then, everything around them being responsible for safety. Now, of course, when I mentioned before, like this kind of tiers of support, and that's something we really need to consider here, because not every person who qualifies for psilocybin under the Medical Act may need a large expansive care team. So I want to show you a couple of examples of patient profiles and what service levels might be appropriate. So I think work would likely need to be done at the outset to surface, the patient data, individual needs, and then provider mapping to find a good match. This is where a HIPAA compliant tool that could automate some of this decisioning with a human in the loop could be really, really valuable. And I hope we can explore it at some point. So for example, somebody who's been recently diagnosed with cancer, who's a non-practicing Jew, may have appropriate support option would be like a licensed therapist, plus say an unlicensed wellness facilitator or doula. And then up into somebody who's medically complex, say late stage ALS, and identifies as a Baptist Christian, may be best served by a physician or nurse plus a chaplain. And again, this idea that we could automate some of this with an intake tool that has rules-based matching could right size and right map support while ensuring adequate coverage. So back to this kind of general idea of this spiritual care roles. These are some of the things that I think should be part of this, providing, again, that spiritual and existential support, using that non-directive listening, providing the legacy and life review, and then advocating for alignment between their values and the care environment, and then participating as a member of the care team. So in the hospice setting, the chaplain, traditional chaplain role, one of the tools they use is that spiritual assessment. And so I'm proposing that the psychedelic chaplain role would specifically be in charge of this. And this would be to really like document the patient's spiritual history, beliefs, values, existential concerns, and then identify spiritual or existential distress relevant to their psilocybin assisted care. So this process could occur during the early engagement phase in the preparation sessions, and that precedes the dosing day, so like a week or so before. And these frameworks here are used to solely guide attentive listening and support ethical presence and identify areas of existential concern. They're not used as diagnostic tools, and they reinforce the role of the chaplains as specialists in meaning making and spiritual care within that interdisciplinary psychedelic end-of-life setting. These are some of the tools that are used. There's the ONC framework, there's the SP facet and the demoralization scale. And of course, these aren't mandatory. These are just some of the tools that are used. And these are some of the questions that come up in the ONC framework. Am I a burden? Has my life mattered? Is there unresolved connection? Is there fear of non-being or loss of identity? And are my beliefs being honored? So you can see how that's built out there. And this is kind of a patient journey example. So this would be a proposed care model in a dyad format. So say with like a psychedelic chaplain or eligible qualified doula and a licensed facilitator. So there would be start with an early engagement with the eligibility check and assessment. And then there would be the preparation day, and then the dosing day, and then the integration. And this journey includes that early engagement, preparation sessions, medically supervised dosing, integration. And these are the functions I sort of built out here. So the medical risk assessment would be done by the licensed clinician, the psychological screening by a licensed clinician, meaning making and legacy, death is chaplain or death doula, vigil, presence, sacred witnessing done by the chaplain or doula, and the clinical escalation always by the clinician. And these are some of the questions that came up for me, and I'm hoping we can address, and maybe we can sort of document these or go through these. But what came up for me was that I wanted to discuss with you all is how valuable is spiritual care for end-of-life indications, and does the current language reflect that adequately enough? And now we get into a question of supply and demand. Do we know what the pipeline is? Do we know how many board certified chaplains there are in New Mexico who are interested in psychedelic assisted care? Or do we know how many unlicensed practitioners we have? Should a policy include a tiered model of support based on degrees of end-of-life situations? And then how can we ensure the right level of care? Should the definition broaden to include culturally sourced spiritual caregivers and community leaders? And should the framework emphasize group supervision specific to psychedelic spiritual care? So I wanted to, this is kind of the last slide I have. So New Mexico's model, I feel, would be best served by cross competency. Mental health clinicians should possess foundational literacy in spiritual and existential care, while spiritual care providers, including chaplains and doulas, must demonstrate basic competency in behavioral health, trauma awareness, and risk recognition. And so I wanted to just kind of talk about how do we get there? So I wanted to show some of the organizations, institutions, learning and experience opportunities that are building this learning pathway. And again, this is in a time when we don't have standardized training for a board certified psychedelic chaplain or even doulas. So I wanted to show you here, okay, so there's an organization called Transforming Chaplaincy Psychedelics Network. Then we have Harvard Divinity School, Emory University, Southwest College in Santa Fe, Naropa University, End of Life Psychedelic Care, Congregation of Sacred Practices, and then Modern Spirit. And again, none of these are offering like psychedelic chaplaincy degrees, but I think they're at the forefront of that thought leadership and starting to build out those experiential learning paths or discussions, workshops, etc. So then this could be helpful for folks who are trying to get their continuing education or just want to stay in tune with the thought leaders and the opportunities to learn. So this is not really in order, it's sort of in order, but this is what's coming up that you might want to plug into or explore. First of all, March 26th, Emory University is having their Science on Spiritual Health Symposium, and this is both virtual and in person. So Harvard Psychedelic Intersections 2026 has a lot of conversation on this topic. That's in April. And then Modern Spirit, Joe Tafour's organization has some opportunities for healthcare providers coming up where they can actually go and sit with sacred medicine in Colombia. And there's two groups coming up, one in July, one in August. And really the focus is on like building that sort of interdisciplinary awareness and helping healthcare providers really understand the role of plant medicine. And then there's another organization that I've been hearing about called Congregation of Sacred Practices. And mind you, I haven't talked with them. I don't know a whole lot, but I've listened to a couple of podcasts which intrigued me. And they have a ministerial training program. And they have an accredited seminary, and they combine a lot of like live training, a live community, and they do a lot of like swapping of learning. So you sit for people, they sit for you, and I think they require like several sessions of sittings instead of like one retreat you go to, and maybe you'll do a psilocybin sitting for one person. They make sure you get a lot of opportunities to do it, and they are completely oriented around spirituality. They're taking applications for the fall. Again, I haven't vetted them and checked them out, but I wanted to at least bring that up. And of course, there's End of Life Psychedelic Care. They have a psychedelic core course that's underway. And there's an End of Life doula training starting in May.
Hey Jen, can I
Yeah.
stop you real quick? I'm wondering if you, and actually you too, Larry, if you guys could turn off like your camera video, I think that might help. Because right now, the presentation is just like a little blurry, and I think if you both turn off your like webcam cameras, it might help the presentation be not as
Oh,
blurry
okay.
as often. Okay,
How's
cool.
that?
I think
Does that help?
that'll help a little bit. Thanks.
Okay. Okay, great. All right. So, and then one thing I wanted to point out there that End of Life Psychedelic Care started doing research on death work practices. And I know Christine Caldwell unveiled some of her early findings at the MAPS conference in Denver in June, the first slice of it. And it looks like there's a webinar on some of the more of the findings taking place in February. And I highly recommend everybody take a look at that. I know it really helps me really understand the practices in the field, kind of who's doing it, what kind of care is provided, and what just sort of what's emerging in the field as a standard of practice. So I think that's going to be really insightful too, and could probably help this conversation. And that's all I have, and I'm sure everybody else has more they want to add, but I just wanted to give kind of a first glimpse of what's coming up, where we could all sort of gather and continue that learning and connection building. So I think we're getting to the end of this presentation. So the next step for the committee is to explore more accessible pathways to the spiritual care role. For example, could we look at opportunities for group supervision if folks want to get more training without spending a ton of money or, seeking out programs here and there? Could we build in some group supervision opportunities? And then just today, actually, MAPS put out their policy guidebook. And within it, there's a section called Interactions with the Existing Healthcare section, Healthcare System section. And I have a link to that here. You could just go to the MAPS link and find it. But this has a lot of references to New Mexico versus Oregon and Colorado. And I felt that after reading, I felt like I was really aligned with their thinking, and the folks that helped me with this presentation seemed to be aligned with it as well. So I recommend everybody go and take a look.
Well, and sorry, it's still kind of blurry. If you could post that link in the chat as well, that'd be super helpful.
Yeah, I can do that as we're chatting. Yeah. And that's really it. I think I might have gotten through that a little faster than I thought.
Jen, this is Larry. That was great. I've gotten like gotten a lot of texts and enthusiasm. That was a beautiful presentation. We all thank you so much for doing that. I think if it's okay with you, we can open up the floor to questions for you.
Yeah, and if I can't answer any of these questions, I'm sure there's somebody else in the conversation who probably could. So I would encourage other folks to chime in as well.
And just so everybody knows, we've put the information on how to raise your hand and also how to unmute once we call your name in the chat. And so if you're interested or have any questions or comments, please go ahead and raise your hand at this time.
Thank you, Dominic. First up to speak is Hannah Rose. Hannah, your microphone credentials have been enabled. Go ahead and unmute yourself whenever you're ready, please.
Thank you. So nice to see all these beautiful faces again today. I am a BSW student here in Silver City, New Mexico, and first generation curandera. Thank you for this beautiful presentation. Some of my thought processes as you were presenting were around your questions with research around how many practitioners do we have in New Mexico. So one of the areas of social work that we are committed to in our code of ethics is research, research-based informed practice. And so I would like to offer my services as a volunteer, since I'm not a licensed social worker yet, to support gathering this research that it seems like we need for this program.
I was on mute. Are you talking about collecting data on the whole gamut of licensed and unlicensed potential practitioners?
I'm speaking to collecting data on the unlicensed practitioners because I'd like to support that that DEI, that diversity, equity, and inclusion piece.
Yeah, that sounds like really incredible, an incredible offer and something that we absolutely need. So how can folks get in touch with you? How can we build that into the next phase?
I can include my email and contact information wherever it seems appropriate in the chat, however, and people can reach out to me directly, and then I can support forming a research team. Maybe that means pulling in licensed social workers. I mean, it most definitely means that since I'm just a student. And whomever else wants to be on the team. And then we could do some research and go through that process. And then I can, report back and inform back to everyone.
Awesome. Thank you so much for the offer.
You're so welcome. Thank you. And just let me know where I should put my contact info.
I think probably in the chat for now. Any other, Larry, do you have any suggestions on how we can stay connected to this?
I would recommend, Hannah, this is Jorge, just if you would leave your email in the chat, that would be great, because we also put that into the minutes as well. That's captured in the minutes, and the minutes will also be posted. So probably not your phone number, and just your email address would suffice.
Thank you, Jorge. Next up is Chris. Chris, I've enabled your microphone credentials. You may unmute yourself whenever you're ready.
All right, Jen, that was fabulous. Thank you so much. I just wanted to share a quick story. I was on the phone this morning with Dr. Valerie Masuda. She is one of the co-developers of Roots to Thrive group psilocybin therapy model in Canada. And she's gone on to develop her own more spiritually oriented protocol. And she was saying something that I didn't see captured yet on your presentation in terms of the roles that a chaplain could play. And that is, she said, we always take our participants through a spiritual experience before the psychedelic journey. And what she meant by that was a sound bath, a drumming, other contemplative practices. Because she says, in order to have a spiritual experience on psychedelics, you need to have a spiritual experience beforehand, and it really helps that individual let go and embrace whatever shows up. So I just wanted to throw that out there.
I love it. Yeah, that really goes into that realm of like experiential learning. And also, how do you differentiate between, you don't always need psychedelics to have a spiritual experience, right? And so I think we need to ground that reality into something. So I love that. Thank you for bringing that up. And I know a lot of us have opportunities to provide that for others. So it'd be good to like, maybe we create that resource list too, who's offering those kind of experiences.
Thank you. Next up to speak is Kate. Kate, I've enabled your microphone credentials. You may unmute yourself.
Hi, everybody. Yeah, this is Kate Hawk. I'm so glad we're all doing this. Thanks for putting together so much there, Jen, in such a nice, organized way. I just want to mention I'm doing a project to map out all of the everything I can find that's happening in the world of psychedelics and end of life, and doing interviews, including some of the people who are on this call. So anybody, I'll put my email in the chat, and anybody who wants to get connected, I'd be happy to talk with you and stay connected. That's all.
Awesome. Will you be publishing the results somewhere and making that available publicly?
Kate, your microphone is still enabled.
Oh, I got muted again. Okay. Yeah, I'll be putting things on my website, and we'll see. There may be a book here sometime, but first it's just a project that I'm going to put resources on my website. But I'll put that in the chat.
Thank you so much, Kate. Next up is James Brown. James, I've enabled your microphone.
Hello, Jen. James Brown, Doctor of Pharmacy here in New Mexico. Great presentation. Thank you so much for providing that information to us. And Larry, thank you for having her on. My question revolves around set and setting. When you think about the chaplains and you think about the set and setting of death doulas and you guys sitting in these spaces in the container that is going to be required to maintain, where do you see that set and setting occurring? Do you see it set and setting in a building, an actual physical location? Or do you also see the set and setting at home? What are you guys going to be advocating for, and what do you see that vision as in that set and setting?
That's a great question. And I mean, I think it's wherever the patient is most comfortable and where I would make it a patient decision. Hopefully there'll be enough flexibility for that. Also, when I was thinking about the doula role, I think when I had some doula training, there was a lot about creating the set and setting and bringing in the flowers and like making sure the environment is pleasurable, bringing in music and whatnot. So I think just yes, it's the where that's important because of accessibility, but it's also the kind of content of the setting itself that I think is going to be really important. So I've heard of people really doing a great job in making a beautiful environment in a hospital room, if need be, or in a physical building. But I think it's going to depend on where the patient can get to, or where people can get to the patient. So, but I think at home is always a good idea if the home is safe and clean and whatnot, and depending on what stage the patient is at.
Thank you, James. Thank you, Jen. Next up to speak is Candy. Candy, I've enabled your microphone. You may begin when you're ready. Just a friendly reminder, Candy, you can tap on the microphone icon. That'll go ahead and unmute your mic so you can speak. So what we're going to do, Candy, is we're going to move on to the next person in line. If you want to go ahead and drop off the meeting back in, that usually resolves most technical issues. Next up is Jay. Jay, I've enabled your microphone credentials. You may unmute yourself whenever you're ready. Okay, and just one more time, friendly reminder, folks, to unmute yourself on the Teams app, simply click the mic icon. If that microphone icon is grayed out, that may mean that your device is not recognizing whatever you're utilizing currently as a microphone. Please ensure that that input is in place. And like I said earlier, worst case scenario, you may have to drop off the chat and then drop back in. At this point, next in line is Jamie. Jamie, I've enabled your microphone credentials. You may unmute yourself whenever you're ready.
Hi, Jen. It's nice to see you here. Thank you for the presentation. I'm Jamie, a professional chaplain and educator for chaplains, and also was one of the founders of Europa Psychedelic Therapy Program, and have participated in this conversation about psychedelic chaplaincy. I guess for me, the challenge is to really match the care seeker, or who we might call the client or the patient, with the right practitioner or practitioners in a way that creates, the optimal conditions for access, so that it isn't expensive and it isn't burdensome, and it's also safe. And so I'm encouraged by this idea of a research project to kind of look at different competencies and how that might match with different patient populations. I'm also curious, each one of these groups is challenged in terms of the experience that they would bring. So a lot of professional chaplains would perhaps not have much experience with psychedelic medicines, although some of us do, but, so that would be the challenge. And then, physicians might have limited training in spiritual care or even in palliative care. And so I think just commenting on this opportunity and challenge. And when it comes to the death doulas, I'm curious, how the death doulas, and maybe we'll talk about this next time, but how will they, obtain the kind of experience that they would need in order to go into this situation with such vulnerable folks? Because most of the other practitioners are able to, accumulate these hours and hours of kind of supervised time, and where they're getting feedback. And can you just comment a little bit, give a little bit of a preview of this, how we might address this with the death doula community? Perhaps some others, would some of the death doulas probably have dual kinds of backgrounds. So they might be a nurse and a doula, or maybe an underground psychedelic practitioner and a doula, or something that would give that kind of experience with some sort of mentorship.
Yeah. Yeah, no, I'd love to hear from others, but I mean, there's been some chat and discussion about a group, the group training, again, that apprenticeship and mentorship and all of that, but that needs to be kind of built in, and there's got to be like a pathway, like there has to be an offering to be like, okay, here's a group assembling. Everybody who wants to get that, to be eligible to serve needs to have, 12 hours or whatnot. So I think just getting really formal about what that looks like would be really helpful. I'd love to hear from others too.
Yeah, I mean, I guess just to throw out my concern is that the I would want to see it more in like the 100 hours or something, more than 12, and for likewise for the chaplains or for the other providers, this kind of the gaps in experience that we would bring would be important for all the disciplines. So chaplains, I wouldn't want to see a chaplain just take a a quick course in psychedelic care and then jump into a situation either with, let's say they've never experienced psychedelics themselves. So these are just some of the challenges, you know, to make sure people have enough supervised experience, enough experience with the medicines that they're sitting for, and enough experience with palliative care. So while there's still opportunities for access, so I would suspect that having group opportunities would help with access and also training. Perhaps people could train in a group with other practitioners present or something like that. I'm not sure what the solution would be.
Yeah, and as you brought up, like what is that number of hours that ensures competency, and how do we measure that? I think that's something we're going to have to figure out. What's the right number of hours that's on parity with other roles? Is it 12 or is it 100? Or something in between? Yeah, others are coming up here.
Thank you, Jamie. Thank you. All right, next up is Jay. Jay, I've enabled your microphone credentials. You may unmute yourself whenever you're ready. Jay, just as a friendly reminder, please ensure that you have selected the microphone icon. Unfortunately, we still can't hear you, Jay, so what we'll do is I'll next in line to Chris. Chris, your microphone credentials have been enabled. Go ahead and unmute yourself, please.
Yeah, thank you. Yeah, I want to just to say a quick comment about the doula versus the chaplain. In my experience, doulas and chaplains do phenomenal work, both of them. So what we're really talking about is appropriate training. And so I think as long as both receive appropriate training to work with psychedelics with people toward the end of life, then I don't see any distinction.
Thank you so much, Chris. Next is Dr. Lida. Dr. Lida, I've enabled your microphone. You may unmute yourself.
Thank you so much for this presentation, Jen. This has been amazing. And, you know, having the lens of spirituality going into psychedelic care, I see that so valuable, especially at the end of life. I'm also a hospice physician, excuse me, and a program director for the Conscious Physician Psychedelics Academy. We're also a CMA accredited organization through UNM School of Medicine. And the conversation around having group, you know, we have 11 staff members from Red Willow Hospice who are part of this cohort in our academy right now, and 2 of them are chaplains. And we're just, you know, there's just such rich conversations and teachings. And yeah, our program, we're looking at, you know, 150 or 60 hours of actual didactics and practicum and in-person immersive, and also mentorship and following others in the community who are doing this work. So I think, you know, it has to be, in my experience, when you have all those components in a training program to be comprehensive, and then we have, you know, a month long just talking about end of life, though this program is not just for end of life care. In fact, Chris Caldwell is going to be talking to our cohort as well. But, you know, I'm a big fan of having a multidisciplinary group come together and educate together, because the wisdom sharing is so beneficial amongst all professions. We have many physicians in this group. We have therapists, social workers, again, chaplains, and RNs, NPs, which makes it much more rich than if it was, let's say, just physicians, you know. So thank you for this work. And yeah, I think the hours, you know, I was thinking about that too. It's some people come in with a very significant psychedelic experience themselves, and I think that has to be counted in as where is the individual in their own journey with these therapeutic medicines and their own healing, perhaps, when they start a program. And yeah, anyways, things to figure out.
Yeah.
Thank you so much.
Great to learn about your program too, Lita.
Yeah, thank you.
Thank you, Dr. Lita. And I see in the chat, thank you, Jay, for including that in the chat. For whatever reason, the microphone wasn't working for you, but yes, definitely feel free to enter that in the chat as that is monitored and minutes are being taken. Next up is Hannah Rose. Hannah, I've enabled your microphone. You may unmute yourself when you're ready.
Thank you so much. Jen, I wanted to respond to your question on how do we measure these things? So in social work, the way we measure things is called SMART goals. And so we have, it's specific, measurable, time sensitive, research-based, all the things that go with the SMART goals. So that's my answer to your question on how do we measure this. And then Dr. Lita, your question on your curiosity around people coming in excited, right? They have lots of psychedelic experience. How do we make sure everybody is safe? And so again, through a social work lens, the way we do this is through grounded practice, which is research-based informed practice, which means experience, right? Which means we're not going to negate these populations coming in excited, and I believe this is an opportunity then to take that excitement with these populations and say, great, you have all this psychedelic experience, come into our program, do the thing. And then they'll have to go through their self-reflection, go through their deconstructing internalized racism, prejudice, biases. They'll be forced to do their own work, and it'll just filter out the populations that, aren't quite ready in that moment. Thank you.
Thank you, Hannah. I appreciate that. Next up is Candy. Candy, I've allowed your microphone credentials. Please unmute yourself whenever you're ready.
Okay, let's try this again. Hi, everybody. I'm Candy Werman, and this is my first time here. I live in Oregon. I'm a board certified chaplain, longtime hospice chaplain, and been in the psychedelic world and relocating to New Mexico. So I wanted to begin to get involved. And thank you so much, Jen, for your extensive presentation about spiritual care, about chaplaincy. And I'm so honored that at least maybe it's a long-term goal to have the interdisciplinary approach. And I really appreciate the discussion about how are those that are not certified or put differently, unlicensed and don't have the depth of spiritual experience, like a death doula, that to how to make that a safe practice, a safe presence. And then the other piece that really hit me is in that practice or in that teaching to be able to also teach what is their limitation of their scope of practice so that one knows when to call in a chaplain. You mentioned the non-practicing Jew, but for a chaplain to be present in that psychedelic piece, they could have all sorts of things come up that could have meaning for them as a Jew. That's just one example that really hit me. And I'm just really excited that this is happening in New Mexico. And I've been involved with Emory and Transforming Chaplaincy Psychedelic Care Network. So I'm very excited to be involved, and it's lovely to meet all of you. Thank you.
Thank you, Candy. At this point, there are no hands up. So I pass it back to Jorge and Jen and Dr. Leeman.
Oh, thanks everyone for all your questions and things you brought up. There's a lot here. And so I love that we're all kind of digging into some of these nuances.
Jenn, that was a great talk. Everyone's questions were really good too. I mean, I do think we're kind of having several kind of special situations here in New Mexico that really can allow us to move forward as leaders in this. Obviously, the bill itself, the Red Willow team in Taos has received a grant for a grow model psychedelic hospice, and I know there's a few people. Does anyone from Red Willow want to just mention a little bit about your plans and your program? I think it would be interesting for people. Asher, are you on? I see your chaplain up there. Would you be able to just share a little information about that?
Asher, your microphone is enabled. You may unmute yourself whenever you're ready.
While Asher's getting her mic going, we had a comment from Deb Thorne about the sadness is that there's number of people that are presented that are interested in this care, and that they likely won't be surviving to the point in time when we move it forward. I think as we look at ways to accelerate the program, from my perspective, end of life is one that could potentially be kind of first in line for, to get some pilots going. The fact that potentially can be done at home. I just think I appreciate, Deb, what you say, sort of the urgency of trying to make this available to people as soon as possible. I'm thinking maybe Asher's not able to log on. Asher, I'm definitely not the audiovisual expert here, but I think some people have. Looks like your mic is still off, based on there. So there's a button if you're on your screen on the upper right for the mic. If you click it, it should turn on. And no worries if you can't connect. Actually, maybe we can have somebody from from Red Willow come to a future meeting to to talk and present things. I do want to mention, if anyone has any thoughts on other areas to cover in our self education, please send them to me. It looks like Asher might. Oh no, she's still muted there.
Asher,
How is
go ahead.
this? Is this working?
Perfect.
Sorry about that, everybody. Yeah, I am very new to Red Willow, so I'll just speak briefly from what I know, that there are chaplains and nurses and physicians working with Dr. Lita, who's on the call here. And I do know that we are also looking at doing ketamine-assisted psychedelic therapy. And yeah, we're just working on getting people certified and getting kind of training protocols in place, and just really staying up to date on everything that's going on here to try and be the front of the line to offer this medicine through hospice. And yeah, that's about as much as I know specifically. Maybe Dr. Leda would be able to say some more as well, but thank you for calling on me here.
Thank you, Asher. Appreciate it. I had one other thought that this would be for Jenn or maybe Jamie. Is there some and this may already be happening, but to outreach to chaplains in New Mexico, and potentially do presentations, and that may all already happen, but I'm just thinking about addressing what I think Jamie mentioned, that many chaplains aren't familiar with psychedelic assisted end of life care.
Yeah. I was going to mention something about that. I started doing a little bit of outreach to the hospice I worked with this last year, and I got some pushback. So I'm wondering if I went back, if it would be a little more open. But the pushback I got was, we're not doing anything unless our medical supervisor wants us to do something. So I think I mentioned this in the last call. I think doing some outreach to the medical supervisors is kind of the first step. I'm actually going to reach out to the other hospice in Sierra County and see if they would be open to some kind of discussion and communication around this. So I'm going to do it in my community, and it might be worth everybody kind of reaching out in their county and doing something similar and just spread the task.
Yeah, if it's helpful, I'm going to volunteer Linus, and she's on the call. Either Linus or myself, I'm sure would be happy to just, if you had like a medical director that didn't have the information and felt more comfortable talking to a physician, we could talk to them, send some information, just to put that out.
That would
as
be
an offer.
fantastic. Okay, thank you.
So I wanted to bring up one issue that I've been thinking about here, which is, so we talk about the role of chaplain, death doulas, but how will that work in some of our native communities? Is that going to be like potentially a medicine person from one of the pueblos, or from Dene? So I was going to reach out to a couple of people that I know from those communities and see and see.
We've got the meeting going on, but no, but they're doing all their stuff, and
I will, kind of reach out, because I think that would be good for us to actually see if we can get some viewpoints from the indigenous community on how to do that. Hannah, I know you're a curandera, so that's that may be relevant to you too.
Anna, I've unmuted your microphone. I've enabled your microphone. You may unmute.
Thank you. Yeah, so in social work practice, this is where a social worker, a licensed social worker, comes in and can be a bridge to these marginalized populations. And so I'm highlighting just with my presence the importance, like the not only the importance of licensed social workers' involvement here, but where I really am good at seeing where there's gaps and how to fill those. And so this would be a way. So get a social worker, licensed social worker, then to reach out to these tribal lands, these ancestral populations, and start to do that work that social work does so well, which is relating to marginalized populations, giving them a voice, doing whatever research is needed. We do all that. There's so many steps in social work, and so we have 6 core competencies. Our code of ethics is so long, and we go through all of this slowly, and we make sure we're self-reflecting, and make sure we're combing through all of these kind of checkpoints, and then the first and foremost thing of our practice is client self-determination. And so this would kind of be like a little twist on that. It would be self-determination for marginalized populations and cultural sensitivities.
Thank you.
Larry, I saw that Jamie Beachy had raised her hand earlier.
Let me see. I appreciate that. I've went ahead and enabled your microphone credentials. Then unmute yourself whenever you're ready.
Oh, hi. Thanks, Jen. Yeah, for some reason, I'm not able to contribute to the chat. I think it's my settings or something, but I just wanted to say that I'd be happy to contribute to some kind of educational outreach to spiritual health, practitioners in the state, chaplains or other people who are doing spiritual care as palliative clinicians, like nurses or social workers, other practitioners. I think that we could go through the hospice organizations and maybe some of the chaplaincy, like the chaplaincy certification groups, and see if anyone would be interested in learning a little bit more.
Thank you, James.
Any other questions, topics for discussion, or?
Yeah, actually, I wanted to just bring up Red Willow's training program. I'm really curious if it would be an offering they could roll out to others, or at least, help kind of get other hospices started. So I think a lot of them just don't know. They're coming from they don't know where to go. They don't know how to start this whole thing. So almost like a replicable model. And if they'll be kind of putting together a presentation or something like how we did it or how we're doing it, and here's what you should think about to help other hospices, or is that in other parts of the state, not competing with their territories?
I certainly don't want to speak for them, but I do, when I did have some conversations, I think they're still in the ramp up phase where they're getting on-site training, getting everyone sort of trained up, and I think their grant is just starting here now. So I have suspect it may take a little bit of time before they have something to share, but it would be great to have like a model in the state that's well known and get that information out.
Dr. Lida, your microphone credentials have been enabled. You may unmute yourself whenever you are ready.
Thank you so much. Yeah, it's regarding Red Willow, they don't have a training program. They're going through my training program with the Conscious Physicians Psychedelics Academy. They're utilizing their psychedelic grant that they received. And yes, they have used ketamine in the past, and they just want to expand now that psilocybin is on the table. Their medical director and co-founder, both Joanna Hooper, Dr. Hooper, and Robin, they're very open to bringing in other modalities and making sure that they're just wonderful people is really what it comes down to. And so, yeah, they have a psychedelic grant that they're utilizing to enroll their staff into my Conscious Physicians program. And so yeah, our program is ready to go for all of New Mexico. It's a homegrown psychedelics program. It's been going on for 5 years. I've been doing the research for over a decade, and started Conscious Physician in 2020. Then a few years later, started training others. I trained other therapy groups in town of 20 plus members, and with great success of just education. And anyways, it's been really great. Now this is a more extensive program that I'm offering. That's a 9-month course. It's 3 trimesters that's mimicking human gestation. The first trimester about self-care, self-compassion, because a lot of us in this field of not only healthcare, but also facilitation, we get burnt out, just like the, unfortunately, recent news that we had on the Ibogaine researcher, renowned Ibogaine researcher in California, who committed suicide, a physician a day kills themselves. And so remembering that we all need to have very deep foundations of self-care, self-compassion before we can hold these spaces for others. The second trimester is about, we're going to have a retreat that's going to be in person, immersive with medicine, with a third party involvement. With CPPA does not touch medicine. We're over the ground, and it's going to be held outside of the state to ensure legality. And the second trimester is all about integration for 3 months. And the third trimester is mentorship, apprenticeship, and practicum with other faculty in the state and outside of the state, because we have people from all over the country who are enrolled in a program. We have 27 members as we speak. Again, we're going to probably end up at 160 hours total of including both didactic and non-didactic group sessions, small group sessions, apprenticeships, mentorships, practicum for self-discovery, practicum for sitting for others. Probably we're going to end up at around 165 hours or so. But that's kind of the overview of our offering. And 16 out of 24 of our guest faculty are New Mexico residents. They're here. Majority of our members who have signed up and registered are in New Mexico. And we take really big pride in that. And we have Indigenous representation on our guest faculty and facilitators as well, which we take big pride on as well. New Mexicans, who are doing this work, And so, yeah, that's about the program. I know you guys were asking about it. That's why I'm sharing. Ask questions if you have more. Thank you.
Lida, thank you for giving us a summary of the program. We appreciate it. If we don't have anything else, then we might be able to give people time back. I just want to let people know we do have times that I put in the chat for the next 2 meetings. We have educational presentations there from Danielle, deaf doula on the committee, and then James Brown. And then I think at the next meeting we'll talk about the idea of how to do an in-person blended meeting, so we can have some conversations in that way. Any other thoughts or comments or anything before we allow the committee to sign off for the day? Jen, just amazing talk. I mean, everyone's very much blown away with the depth of what you shared. So thanks again.
Thanks to you, and thanks for everybody who I was able to talk to in the weeks coming after this. It was really incredible.
All right, well, we'll see everybody, as many as possible, hopefully here at March 20th at the meeting where Danielle is going to be presenting. And I think it's really helpful to get the different models. We get the spiritual chaplain model, the deaf doula model, information about, hopefully, get all this information will allow us to, develop our recommendations. Bye, everybody.
Thank you, everyone.